The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Hello everyone, and welcome to Health and Wellness. My name is Paul Drezelo, and I'll be your host. Today we're going to be talking about allergies and asthma and some of their related conditions. Topics like diagnosing and treating, of course, as well as topics like how your environment, your lifestyle, and your house might impact these conditions. So to help us talk about some of these, we're very fortunate today to have with us Dr. Scott Osur, who is a certified allergy and immunologist, I believe I pronounced that right, with certified allergy and asthma consultants with offices located throughout the area here. So welcome, Dr. Osur, and it's really great having you here today, of course.
Thank you. Thank you for inviting me.
Yep, not a problem at all. So why don't we just start in with a couple, some general topics about allergies and asthma, both together, basically, and we'll just see what information we can put across. So, what are the main types of allergy and asthma conditions that people typically run across?
Well, we see a variety of allergy conditions. Of course, asthma, you mentioned, is very common. Nasal allergies or allergic rhinitis, which also affect the eyes, particularly this time of year in ragweed season. We're seeing increasingly more children with food allergies. We take care of skin allergies such as eczema or contact dermatitis. We'll see patients with hives. We'll see medication allergies. We'll see bee sting allergies. And then occasionally we'll see people with immune deficiency disorders, but that's a very small part of our patients that have that problem.
You mentioned that food-related allergies were increasing somewhat. Is there a particular reason for that, or is it just happens to be some kind of unknown phenomenon? Or
yeah, it's still not entirely known why food allergies are increasing. Some of it actually may have to do with the late introduction of highly allergic foods. The current trend in research now is to suggest that actually delay in feeding infants and toddlers potentially allergic foods such as eggs and peanuts and tree nuts actually may lead to more food allergies as they get a little bit older. There seems to be sort of a magic window under a year of age, for example, for peanut allergy. If someone's exposed, they're actually less likely to become allergic than more likely.
Is that the same as like exposure to the outdoors if you kind of like shelter someone somewhat?
Yeah, it's an interesting question, but it doesn't seem to be the same. There's something sort of unique about food allergy and its presentation that if you delay your exposure, you're more likely to be allergic. In terms of environmental allergies, that same sort of information isn't available at this time. We just don't know about that.
Okay. What would be some of the symptoms or the how someone might know that they have a particular allergy or some kind of an asthmatic problem that would bring them to you, basically, versus something just some kind of other condition, or how do you differentiate?
Well, taking, for example, the most common condition we see, allergic rhinitis, you would expect to see nasal congestion, runny nose, itchy nose, sneezing paroxysms, not just one sneeze, but a sequence of sneezes, itchy and watery eyes. And then usually you want to see a repetition of this, perhaps with a particular exposure like a cat or in a particular season, such as, let's say, ragweed season in August and September. And the thing that differentiates that, for example, from a head cold is you don't have a fever, you don't necessarily have yellowish or green nasal discharge or a really severe sore throat. So that would sort of differentiate a cold from allergies.
Okay. Once you know someone basically has some kind of, or someone thinks they have some kind of issue, how do you go about usually diagnosing either a specific allergy problem or something related to asthma? What type of tests and things like that do you actually run?
Well, the first thing we do is we spend a lot of time with the child or adult going over history. Unlike other specialties where physical exam is critical, here the historical details. You're a bit of a detective, looking, as I mentioned before, times of the year, exposures, repetitive nature of symptoms. So spend a lot of time history taking, and then of course we'll do a physical exam. If they have asthma, we might hear wheezing in the chest exam. We might notice decreased aeration when they're taking a deep breath. If they have nasal allergies, we might see pale, whitish, boggy nasal mucosa lining of the nose. But after the history and the physical exam, then we'll want to do some specific testing. The hallmark of being an allergist is doing something called skin testing, where we'll take a particular allergen, perhaps grass pollen or cat dander, or it could be a food such as peanut or a shellfish, and we put a drop of allergy extract on the forearms and just poke through this drop ever so slightly. And what will happen then if someone's allergic is they'll get an immune response right on their arm, and they'll develop a hive, sort of a small mosquito bite type eruption, which identifies them as being allergic. Alternatively, you can also do that through blood testing, something called RAST, which can look at the same things serologically. And both tests can be quite useful in identifying a specific allergic trigger. And then if someone has asthma, for example, we'll do a battery of lung function tests to look at airflow rates and inflammation in the lungs. So those are the two mainstays of our diagnosis, even though there's other things we can do as well.
Have you ever had anyone have any type of really serious reaction to any of these tests, like a skin test?
Yeah, that's a good question. Extremely infrequent to have a severe reaction to a skin test, because you do it just under the surface of the skin. You use a very minute amount of allergen, so 99.99% of the time you're going to get a local reaction. In someone who's incredibly allergic, incredibly sensitive, there's a very small chance this could potentiate a true generalized allergic reaction, but that is a very infrequent event.
Once you have an idea that someone has something and they actually do have something, or you rule something out, conversely, do you ever have to retest people periodically throughout different stages, or is there like a certain amount of time after you test just to be sure?
Well, if you took a child, perhaps at 2 or 3 years of age, they may be allergic, let's say, to animal dander or dust mite, but they haven't been around enough years necessarily to become allergic to pollen, which many times takes several years of sensitization. So it would be very common to test a small child in a very limited way to year-round allergens, and then perhaps when they're 8 or 9, you might want to do a more extensive battery of tests. So that would be a common scenario where you would repeat testing. Another common scenario is if you have someone who's peanut allergic. We know that about 20% of the time you can outgrow peanut allergy. And so you might repeat skin testing or blood testing periodically to look for decreased reactions to suggest that they might then become non-allergic. So you do repeat testing if there's a reason to. If someone has seasonal allergies and they're an adult, generally you don't repeat testing very frequently because they probably have gotten their full amount of allergies they've developed. It's unlikely they'll develop something new, so you don't routinely do it in that particular situation.
Okay, so as you age and you experience more things, either in the environment, food, or whatever, the likelihood of being diagnosed with something like this, allergies or asthma, is significantly declined. So you're not going to necessarily develop a condition as an adult that you've seen as much as more identifying as when you're younger. By
and large, that's true. I mean, there are a few exceptions to that. For example, if you have an adult who all of a sudden gets a pet cat. They may have more exposure, they may become sensitized, they may develop more symptoms, so you might consider testing them. Or if you had someone move from a different part of the country, for example, if they moved from Montana where they're not exposed to the same tree pollen as here, they could develop allergies. But in general, if they're in this area and they're an adult in their 30s and 40s, it would be unusual to develop, for example, new seasonal allergies at that point.
And asthma would be the same thing if you're really...
Yeah. Well, asthma is a little trickier. I mean, it is true that we see most people with asthma onset in childhood or early adult onset, but there's an occasional adult that could develop asthma for the first time in middle age or even older. So that's something you have to keep in mind, but statistically it is less common than finding in a younger adult or child.
Okay. Let's move on a little bit and focus a little bit more on some of the treatments that are available for both areas. So what, generally speaking, what's available for someone either with skin allergies, food allergies, or some kind of an asthmatic condition? What do you usually prescribe or work with?
Well, there's basically three different concepts to approach allergy. The first concept is to identify the allergens you can avoid it if possible. So it all depends. If someone is allergic to lobster, and the treatment of that would be to avoid the offending agent rather than obviously medications. The second treatment you talk about typically would be medication. If you took nasal allergies, we might start with an over-the-counter antihistamine, a Claritin, a Zyrtec, or an Allegra. If that doesn't work, we would use a nasal steroid spray, some of which are now over-the-counter. But the second step is usually medication for whatever condition.
Yep.
And the third step, depending on the condition you're treating, could be allergy desensitization, which is generally done with injections, although there are other ways of doing that, where you start at a low dose and gradually inject an individual with higher doses of a substance, which causes actually an immune response where they become less allergic over time. And that's particularly helpful for seasonal and perennial allergies, somewhat helpful for asthma, may be helpful for eczema, and definitely very helpful for bee sting allergy. Food allergy, there's desensitization protocols people are working on in research, and probably will be available in the next few years. But generally, for food allergies now, the mainstay of treatment is avoidance.
Okay, and that's typically how you kind of look at things, try to get the person to kind of avoid and then treat somewhat with medicine. Then if that doesn't fill the need or the whatever the specific condition is, then try to desensitize. It's usually in that order somewhere.
It generally is in that order, although if you had, for example, a young adult in their 20s and you found they were very allergic to ragweed, and you know that this is going to be a repetitive problem for the next several decades, even though medicine might work, they might be a candidate for desensitization because you'll be able to decrease their medication use for years and years to come. So it depends on what the individual patient is interested in, whether they're interested in medication treatment or actual desensitization. But indeed, you're right. Usually we think of it avoidance, simple medicine, and desensitization.
Okay. Is there any real problems or side effects that with some of the prescription medications or over the counter for that matter that you had mentioned that people should look out for? Anything like that should be aware of?
Well, you certainly always have to be wary of side effects of medications. That's true. I mean, take, for example, antihistamines. For years, people would use Benadryl or diphenhydramine, which is a potent antihistamine, but can be very sedating. And in fact, studies years ago showed that you can be as sedated as much when you're on a normal dose of Benadryl as having a couple of glasses of alcohol. So you have to be wary of that, and that's part of the reason over the last 20 years we've developed several non-sedating antihistamines. If you use a prescription nose spray, a nasal steroid spray, they're very safe, but you have to keep in mind they can cause occasionally nosebleeds, and occasionally, in a very sensitive individual, they could cause increase in intraocular pressure or glaucoma. So there are always side effects to be wary of, but in general, most of the medicines we prescribe as an allergist are generally very safe with rare exceptions, so that side effects are not of great concern.
Okay. Over the past 10, 15 years, there's been a lot of growth, at least in the and different practices around alternative or vitamins and supplements, complementary and alternative medicine. Basically, does that type of approach have any fit into what someone with an allergy or an asthmatic condition might have, or is that just completely not relevant?
Well, I will say that the type of medicine we practice have an open mind in terms of potential alternative treatments. The problem is most of them haven't really been scientifically vetted to look for efficacy.
Right.
So, it's something that I'd be interested in seeing more about and like to see more research and trials done. But in general, most of the medicines that we utilize are the typical ones that have pharmacologic studies that support its effectiveness.
Do you ever see people where they have multiple conditions, where they have an allergy or an asthmatic condition that are managing something else along with it, that the two together might harmfully impact each other? Is there any, or is it usually pretty simple?
Well, it's a good question. I mean, we always, as an allergist or any type of physician, have to be aware of other conditions a patient has, other medicines they're on. One example, for example, is acid reflux or GERD, gastroesophageal reflux disease. That can mimic asthma in terms of cough and chest tightness. If someone has acid reflux, it can actually aggravate asthma. So we have to keep in mind that those two conditions can oftentimes occur. They're very common, and one can aggravate the other condition. And we also have to be aware of other medicines a patient's on. For example, if someone's on a beta blocker for their high blood pressure, that medicine occasionally can affect their asthma in a negative way, so that we have to be aware of interactions of medicines with conditions and interactions with medicines for other conditions that might affect asthma medicine.
Once you begin a medicine or a treatment, does that could that prompt you to be allergic to anything else, or is it that entirely not a possibility, or how does it reduce or increase your susceptibility to some other allergen?
Well, generally, if you are on a specific medicine for allergy, it shouldn't increase your risk of sensitization. Although we do know that individuals with allergic disease tend to get other allergic disease. For example, if you start out with an infant with eczema, you can almost predict that they have a higher chance of food allergy, and as they get older, will develop nasal allergies and very possibly asthma. It's the so-called atopic march. They march from one allergic condition to another. So we do know that there's a sequence of allergy development, but we don't think that the allergy medicines themselves should have any role in increasing allergic conditions.
Okay. If you're, is there anything that you can do? But you mentioned before about avoiding a known allergen. Is there anything you can do in your life itself to reduce or kind of mitigate allergic reactions in any way, or is it just basically you're born and you're going to have certain reactions no matter what you do?
Well, there is a huge genetic predisposition to asthma. So one thing is you can choose your parents correctly, but that's not so easy. But besides the genetic predisposition, there are environmental things you can do. For example, dust mite. Many of your listeners have probably heard about this. Is a major factor in developing nasal allergies and asthma. A little microscopic insect that lives in carpeting, bedding, upholstered furniture. So if you reduce exposure as a young child, you're less likely to develop allergic disease, and that would be not having wall-to-wall carpeting in your bedroom. Washing the bed linen very warm to hot water kills dust mites. If you have allergy-proof encasings around the mattress and pillow, it can make a difference. If you know your pet allergic, of course, not having that pet in the household could be quite effective. The use of air conditioning, keeping windows closed, can reduce pollen exposure, potentially decrease allergic symptoms. So there are a number of things you can do, and as I touched upon earlier, there's a movement towards potentially feeding infants potentially allergic food at a younger age to prevent the development of food allergy. So we're learning more about prevention, but we still have a long way to go in that regard.
about air purifiers? Do they have any impact, or do they recommend them, or is it too much? Or
Electrostatic and HEPA air cleaners can be useful, although I have a feeling many of your listeners probably think they're more effective than otherwise would be the case. I would say that if someone does have a pet cat in their household and they're allergic and they want to keep their pet cat, one of the things to do would be to get an air cleaner for their bedroom, keep the door closed, keep the air cleaner on, and you can remove a lot of the animal dander from their bedroom environment and decrease exposure that way. It's important, though, that you have an air cleaner in a confined space. If you have one air cleaner and all the doors are open in the house, it's just not going to do the job. And also, a small tabletop unit isn't going to do much. You need to go through the mathematics to make sure it cleans the air at least 6 times an hour in the room that it's in to make sure it's effective.
Okay. You mentioned not having wall-to-wall carpeting in your bedroom or elsewhere. Is there certain types of carpeting that's better or worse than others, or is it just basically the carpeting itself is traps?
You know, I think all carpeting is potentially an issue for dust mite allergy. The idea here is dust mites eat debris, skin fragments that we shed or animals shed, ends up in the carpeting. Dust mites are microscopic in size, and if you think about it, even a low-pile carpet like in this room is like a forest of sequoia trees for the dust mite.
Yeah.
They can hide out in there. So potentially any fitted carpet is a problem. If you were to get any carpet, I would recommend getting an area rug, because if you remove the area rug from the bedroom periodically and you put it, for example, outdoors in freezing temperatures, it will kill the dust mites and decrease the colonization of the carpet. And obviously that's a problem. You can't really do that with wall-to-wall carpeting. So you want the smallest washable or area carpet that you can actually remove from the bedroom periodically.
Same thing with pillowcases and mattress covers. Is there any particular type or style that might help or not help?
Yeah, there are specific encasings you can put underneath your sheets or your pillowcases that are impermeable barriers where dust mites can't set up their neighborhood in your mattress and your pillow. And basically, they have a very tight weave, and they become impermeable to the dust mites. Then you wash your bed linen in very warm to hot water, and the encasing doesn't allow any living surface for the dust mites. And these you can get through many national allergy supply companies, or particularly for children who don't mind it, a vinyl encasing on a mattress or pillow works fine as long as it's zipped up and totally encloses it. A lot of adults don't like that because it's, of course, not very comfortable. They'll choose the more expensive encasings, but they can work quite well.
When you do have to clean or vacuum and you have an allergic person in the house, is it best that the person not be in there at the time you're cleaning, vacuuming, whatever, or does it not make any real difference?
No, that's a good point, because although the vacuum cleaner obviously sucks up a lot of the dust from the carpet, it also can resuspend some of them as you go vacuuming over a surface. So if you have a particular individual who's allergic to animal dander that might be in the carpet or dust mite, it would be best for them to not be around when the carpet is vacuumed. Or if they're doing the vacuuming themselves, although it may look a little unusual, they could actually wear a mask over their nose and mouth so they don't inhale as much of the allergen. It could make a difference.
If you're buying a house or moving into someplace, an apartment where someone had a dog or a cat in the past, and you have some kind of an allergy reaction to that, how long after you the dog and the cat has left, can you move in?
Yeah, there were studies done of this a number of years ago, and I remember reading that for cat dander, it can stay around the home for about 6 months.
Okay.
Now, ways you could hasten removal is if you got someone in to do a really good steam cleaning of the carpet, you might be able to remove some of the allergen debris. Or if you bought a new home and put in new carpeting, of course, and remove the old, that would make a big difference. symptoms. But within 6 months, there should be little of the original animal dander still around.
Okay. Is there certain breeds of cats or dogs that are better than others, or is it just the length of the hair? They're totally irrelevant?
Well, it's an interesting question. With dogs and cats, it's a bit different. With dogs, there's many different breeds, and it's conceivable that you could be allergic to several breeds and maybe much less bothered by others. So there can be breed-to-breed difference. And frankly, dog allergy isn't quite as well understood as cat allergy. As a general rule, if you're allergic to cats, you're pretty much going to be allergic to all cats, whether they be short or long hair. If you're able to bathe your cat, which I understand is a little bit of a tricky business, you can actually reduce some of the allergenicity of the skin and hair by removing some of it with that process. But I think some people risk their life and limb if they're going to bathe their cat.
Yeah, that can be. You had mentioned ragweed before. Is there anything else coming up, or that's more like certain months of the year or certain times where you really have to look out for in terms of?
Well, take Albany, Capital District, as an area. We do have definable seasons where specific allergens are around. Tree pollen, birch, maple, and oak, particularly prevalent end of March, April, and May. Mm-hmm. Grass pollen starts early to mid-May, and then June is just a horrible month for grass pollen, which goes into the summer, but by mid-July is sort of on the downswing. We get to middle of August, we get ragweed. That goes on in high amounts for 4-6 weeks. Mold is sort of throughout the whole spring and summer. And then, of course, year-round you have dust mite and animal dander. If you go to different parts of the country, you have different seasons. Mm-hmm. If you go to South Florida, you get grass pollen year-round, right, although you don't get quite as much of a burst as we get around here. If you go to Chicago, you don't want to go there if you're ragweed allergic, because their ragweed counts are 5 to 10 times as high as ours. Okay. So sometimes we can give a little people some guidance as to where they might ultimately locate in terms of their allergen.
All right, so you've obviously been in the field for some time. What have you seen over the course of your career that's either newer than when you started, or looking ahead, say 5-10 years from now, what do you see coming down the path? What's changed over time, or what will change?
Well, it makes me sound like an old guy here. Well, I've been in practice almost 30 years, so it's a fair question. I think I've seen a lot of changes, and sometimes, they're so gradual you don't notice them as you're going through. But I was talking to some pediatricians today, for example, and when I did a training in pediatrics before I did allergy, epinephrine injections were the mainstay of acute asthma treatment. But for the past 30 years, it's inhaled medication. So that was a big change, but you have to really think about what you did 30 years ago. Mm-hmm. We now know, for example, asthma is not just smooth muscle contraction of the airways. We used to always treat it with bronchodilators. We now know inflammation is very important, hence the use of topical steroid medicines people inhale, and a sort of different way of treating that condition. Food allergy, we're right at the cusp now of change. For years, it was said that for food allergy, the treatment choice is avoidance, avoidance, avoidance. Mm-hmm. And very soon, there's going to be treatment algorithms to desensitize, whether it be orally or actually there's a topical sort of bandage that someone can wear that releases allergen and helps desensitize you in that way. So I think we're going to see some remarkable changes in actually treating food allergy. So I've seen a lot of changes over time, but year by year, you just don't recognize those as you're going through it.
All right. So, what is from a personal standpoint? What is your favorite aspect of being, an allergist, a physician who actually works with allergies and asthma? What's your favorite part about coming to work?
Yeah, I think. Well, I'll tell you, I've been very lucky that not a day goes by I actually don't enjoy what I do, because no specific patient is the same as the one that comes before them. They all have unique problems. I think in my field, although not everything I see is necessarily a life-threatening situation, although with food allergy or bee sting allergy could be, I think we have a great chance to improve quality of life.
Right.
You take a child with asthma, if they're not on the right medicines, They're in and out of the emergency room. They're on oral steroids. They can't participate in sports. We can make a big difference in that. If you have an adult with severe environmental allergies, they may not be able to outdoors play golf in grass season. We can make a difference there. So I think it's lifestyle changes that really is something we can do, and it can be very satisfying. And I guess the other aspect is we're sort of like junior detectives in our field. You know, patient comes in with symptoms, and we've got to find out, is there an allergic trigger? What is it? Are there more than one things? How do we identify that? And so sometimes we feel like we're doing a Sherlock Holmes type investigation, which makes it fascinating.
All right. Well, I think we've had a really good show here today, and we put out a lot of good information that people who with these types of conditions would be interested in seeing. So I want to thank you, Dr. Osur, for coming in and taking time out of your really busy schedule to be with us today. And I want to thank you for watching, and I hope you tune in next time for the next edition of Health and Wellness. Take care and have a great day.